Dear Carola, Mr. Vice Chancellor, dear ladies and gentlemen, thank you very much for the invitation. I am proud to be able to be here, and as you may or may not know, in terms of autism, my country, Germany, can be regarded as a developing country. And we do admire the developments, for example, in the United States, where parents-driven, more and more states accept behavior analytical interventions as the thing to do in autism, and so that persons and their families are granted evidence-based care. So my university and our very small autism team were very happy to be asked by Carola and her team to cooperate in the first STEM project many, many years ago. You mentioned it, and that was the first time as well I had the chance to see a beautiful country, a beautiful town, and the Giant's Causeway and everything you have to see here. And we started other activities from then on, and the project we start next week, Erasmus funded, will be one to make the accompanying persons of autistic people in the labor market better, more competent, to give them specific knowledge, because that is another issue. You'll be talking about school a lot today, but what comes after school? And this is still terra incognita, and we'll try to make this better, and we'll cooperate with France, Poland, UK, and Germany. Perhaps we'll produce some good results. Okay, this context to Carola and the positive experience here made us rethink our curricula in Münster. For example, we got a clinical master's course which has an autism module, which now does include a mandatory 40 hours introduction in behavior analysis. This is unique in Germany, and we got this so-called RBT training delivered by BCBAs just to give the students a first idea of the science before we introduce them in evidence-based autism therapy. It's not so easy to find a German language BCBA to deliver these courses, not because there weren't any, but because they are needed in so many places. But it's worth all that. And we all know that behavior analysis as a science covers even many subjects we don't talk about today. So our students receive 20 hours of lecture in behavior-based occupational safety as well, to give them an idea of what can be done with behavior analysis, which is not, had nothing to do without autism, but shows another faceted application. I could further elaborate on this and how much ideas we owe Carola, Mickey, and all the BA community I was happy to meet. However, my topic today is that I'm here as a psychiatrist. So I'm a medical doctor, and I have done postgraduate training in psychiatry and psychotherapy. The training differs slightly from country to country, sometimes even from medical school to medical school, but I will try to talk about the common features of my profession and about the parts a psychiatrist can play in a multidisciplinary team which has to take care for autism. To give an overview, I will talk about psychiatry as such, and then about those aspects in autism care for which I feel psychiatric competence are useful or even necessary. So I will look at the need of correct diagnosis, the problems in differential diagnosis, telling one thing for another, because with a wrong diagnosis, every consequence must be not perfect or not precise. I would like to elaborate a little bit on the phenomenon we call syndromic autism, autism not as such, but accompanying other conditions, and about the limited but existing role of medication in autism. And finally, I'll try to point out why psychiatry and behavior analysis should be natural allies in the field of autism care. And as the Vice Chancellor pointed out, it's not only about science, but also about politics and about how to things make work in societies and how to influence decision makers. And I think that we need every ally we can find. And psychiatry should be one ally of behavior analysis, in my view. Let's start with psychiatry, which is a medical specialty. Not everybody knows that. The general public thinks psychologists, psychotherapists, psychiatrists, something about brain, okay, but that's it. And everybody knows to differentiate a general practitioner from something in the psycho field. But psychiatry is a medical subspecialty. Every psychiatrist, and I did that in the 80s of the last century, starts with a medical school qualification of 5 or 6 years. And afterwards, all medical specialties require residencies. For example, in psychiatry, that takes 5 or 6 years of full-time work in a mental health care unit in a hospital. And what every psychiatrist should at least be able to is diagnosis of mental conditions and medical interventions. And in most countries now, this is not only restricted to diagnosis and medical interventions, but there are also psychotherapeutic competences which are taught. However, behavior analysis, well, you won't find this in any country in psychiatric education. That's a regular element, and even not in those curricula which are called behavior therapy. This has historic reasons. One aspect is that clinical psychology has a very strong position as a cooperating science in the training systems. And for example, in Germany, the best behavior therapists tend to be psychologists, not psychiatrists, because most psychological units and faculties have specialized in that. And there is still this very strong psychoanalytic tradition in psychiatry, so not every psychiatrist would be able to have the same approach. I don't want to talk about this too much, because that is not only interesting as a fascinating example of science history, but it's also highly controversial. And I know that Carola wrote lots of papers about what is behavior analysis, what is CBT, and where are the common grounds and where are the differences. But that, I think, is another topic for another congress. There are also countries where psychiatrists are not at all trained in psychotherapy. But the trend in European countries, at least, is to integrate psychotherapeutic training in the psychiatric education. More of a problem than a psychiatrist without training, and the older colleagues might be such, however, are those who are still clinging to psychoanalysis or psychodynamic approaches. In the field of autism, everybody knows that those approaches are not helpful, but they still exist. It's an historic fact as well. And if you try to talk about autism with a psychoanalyst, you will afterwards have serious doubt whether he or you are living on the same planet. So that's a problem. I must confess, I personally have undergone a training in psychodynamic psychotherapy as well. That's mandatory. In Germany, psychiatrists have to learn 2 different therapy concepts, totally independent of their practical use. You just have to learn 2 of them. Of course, I know what to do when it's about autism, but there again, you cannot be sure that every psychiatrist knows that. But now, what can every psychiatrist do, and what should your partners in psychiatry deliver? First of all, it's diagnosis. And in most countries, I think a psychiatric diagnosis is the first step as well for parents with a child where autism is suspected. Well, they take it to the GP, they take it to the pediatrician, and then perhaps they are referred to a psychiatrist. And many ASD diagnoses turn out to be wrong. That's a problem. There are studies in Germany which say that even technically perfect autism diagnosis, including the ADOS application and other standard tests, half of them turn out to be wrong in the long run. That is not because the instruments are so bad, but because there are so few people applying them, and they are trained, of course, but those who are trained very good in test procedures are not clinically experienced, and vice versa. So even university clinic made diagnoses turn to be half of them not very true. And that's not a fault of those people in the system necessarily, because it's complicated to diagnose autism correctly, because there is not the one autistic symptom, which means, well, it's easier in other parts of medicine. There is one symptom for my eye disorder. I won't see the last rows if I don't need my glasses, and that can be measured, and that's a quite easy thing to give me the correct glasses. That is not true for autism. There is not the one autistic symptom, and there is a lot of phenomenological overlap between ASD and other conditions. And I would like also to mention some neurologic conditions, like some epilepsies, like severe cognitive impairment and personality disorders, and sometimes even OCD, or obsessive compulsive disorders, and anxiety can imitate autism and vice versa. So a number of diagnoses are not correct, and on the other hand, there are people who haven't got a diagnosis but are on the autistic spectrum. And how can we secure quality to deliver services to people who have autism, to deliver good services, but good services don't help if the diagnosis is wrong. Okay, so the key thing is that there is no ASD exclusive single symptom, and on the following slide you see some psychopathologic features that can be associated with ASD. For example, sensation, abnormal sensations, sleeping disorder, eating disorders, emotional and perception patterns, which are common in ASD but are absolutely not exclusive. I think, oh yes, you can read it. Look, for example, at the question of attention. Of course, we got a special attention way of work of someone who has autism. But there are very common symptoms between ADHD and autism, and there is an additional problem that there are not only common symptoms, but there are comorbidities. There are people with autism have ADHD at the same time. So what is due to autism? What is due to ADHD? Is that a philosophical question? What does it mean in practical therapy? But more important is the phenomenological overlap of ASD and other conditions. This slide tries to aggregate the core manifestations of ASD. Let's say that's social interaction as one common symptom, and their occurrence in other disorders, ADHD, anxiety, and OCD. And if you only look at one or two symptoms, there is much room for wrong diagnosis. And this is common in Germany, where there are no quality standards for any autism therapy institutions. In Germany, autism therapy is not placed in healthcare systems, but in the social and disability care systems. And there is nothing which we are promoting here, multidisciplinary, but everybody is doing what he thinks is good to do. And so it might well happen that because of an irritating social behavior, parents are referred to an autism therapy center, whereas the child has very other problematics. And so psychiatric experience, I think, should be helpful, and regular consulting in every place where autism is diagnosed and treated. I would like to make this a little bit more concrete with one example. Let's imagine a person who engages in extremely and time-consuming activities about formal aspects of things, of conditions he lives in, and who has a very ritualized life. Everybody thinks about autism, but you might as well think about obsessive-compulsive disorder. That's okay if you only know this. And then which aspects might speak for OCD or which for ASD, and how can we find out? Of course, we have to ask the person about why the things are like that. Well, Carola would call this private behavior. Huh? Things you cannot see, you cannot measure from the outside, but are in the person's brain. And if the person then answers that without a consequent fight for formal correctness, this world is going to collapse, or that without 10 or 15 controls of the checking of the door of his apartments, this might be opened by burglars, we'll tend to try in the direction of OCD, because OCD is anxiety-driven. Things might turn out bad if I don't control, if I don't look at the water, and so on. However, if the person answers that sorting things and controlling the house gives him or her a good feeling, and that sort of activities gives him or her a feeling of being whole, then we would think of ASD. So the observable behavior is fine to see, but asking the person, if you communicate with the person, what are the motives for the behavior is helpful as well. That's not only la pour la, but the therapeutic consequences are totally different. In the case of OCD, you will have a very fast and significant symptom reduction by the technique called exposure plus response prevention. For example, if you have an OCD, which includes that you need to wash your hands over and over hours and hours, then you make the person stop this behavior, and this person will react with anxiety. And after a few minutes, that is true for the treatment of anxiety disorders as well, this panic is receding, and the heart rhythm is coming to a normal rhythm again, and the adrenaline level is going down, and, well, I survived not washing my hands for 2 hours, or I survived not controlling my door locks for 10, 20, or 30 times. That's a good strategy, and it does work. That's the strategy in OCD, but some persons still need additional treatment with antidepressant, with serotonin reuptake inhibitors, for example. But this would be a totally absurd strategy for a person with ASD who engages in repetitive behavior. That wouldn't work at all. That would, well, you could call it a sort of torture. So you mustn't do that. And the medical treatment of OCD wouldn't be helpful at all in autism. So it's not trivial. It's very important to differentiate what is this and what is that. And you could make this for all these examples over there. There are lots of people in the adult autistic spectrum who are misdiagnosed at personality disorders, and the other way around as well. My wife is working with adult people from the autistic spectrum very lot, and there are lots of people who in an adult age see their biography and think, well, I've read so much in the internet and I've been in a cinema, and now I think I've got Asperger's. And please tell me if that's correct, but because if I've got Asperger's, I know why the last 7 marriages didn't work. And that might be very helpful for the individual, but it is not true as a scientific diagnosis. And so there as well, about half of the people who refer themselves to a psychiatrist, and they tell me, have I got Asperger's? I say, no, they haven't got, they got other problems. And there are many reasons why marriages don't work, and only one small part of these reasons might be Asperger's. So the question of personality disorders, I just want to leave it by that, is another important one. Okay, if we got the correct diagnosis now of an autism spectrum condition, another important decision has to be made, because about 20% of those persons on the autistic spectrums suffer from syndromic autism. That means that the autistic behavior is a direct consequence of a specific neurologic or neurodevelopmental condition other than autism. There are some examples you know, for example, Rett syndrome, where in every case there are autistic symptoms in the life of these, mostly girls, and which are totally characteristic. And if the background is not known, the typical behavioral interventions might be started, but they won't not have a significant impact. Here the counseling of the families and an intensive neurologic care are needed instead, but you have to think about that. Or think about Landau-Kleffner. Landau-Kleffner is an epilepsy where children lose speech in the age of 2 or 3 years. That makes us think of autism, of course. And many parents consult autism therapy units saying, well, my daughter, my son has lost speech. He spoke until 2, and then it was everything away. But what these children need is a specific medication that will stop their seizures, and then speech development can restart. So a correct diagnosis in this pseudo-autism is crucial. And another very frequent inherited condition with behavior patterns very close to ASD is Fragile X syndrome. Here, of course, you have to do genetic testing to know what it's about. But as with other types of syndromic autism, behavioral interventions might be considered, but often have very poor responses, and they cannot replace medical treatment where available. So speaking of medical treatment, that would be the next topic. Let me emphasize that, as you all know, the core symptoms of autism do not respond to any known medical treatment. There are lots of promises, there's a lot of abuse of families, of course, but it just doesn't work out. There are only some preliminary data that oxytocin, that is the hormone which makes mother-child bonding and breastfeeding, if you apply that as spray in the nose, that might improve social competencies and empathy in high-functioning persons with autism. But that are preliminary data, and this is far from clinical routine. And that is the only thing where there might be possible to find a pharmacological approach, as we know now, maybe different in 10 years. Nevertheless, there are lots of situations where persons with ASD and their families are suffering, for example, from aggressive or auto-aggressive behavior, or rituals that they're so excessive that they are not compatible with everyday life, and that do not respond or do not yet respond to behavioral interventions, if those are available at all. And you know that in most countries in the world there are no behavioral interventions available. So these families need some, if only symptomatic help as well. And there is a very good evidence that one drug, which is an atypical neuroleptic, corticosteroid, can be helpful in some cases to alleviate the situation for the families, and then perhaps to the next steps make comprehensive behavioral intervention feasible. But that is one part. An interesting new feature is that many individuals with ASD themselves report that they feel less fragmented when they take this drug. Well, this must be an autonomous decision, of course, and they are less driven by the stereotypias, and they do then enjoy greater freedom to widen the behavior or to follow their everyday business. In these cases, ASD-caused impulses are, from an individual point of view, perceived as a restriction. And if those persons feel their condition is improved by medication, of course, it should be made accessible to them. The same is true in some cases for the use of stimulants and hyperactivity and attention deficits. But generally it's to be said that the evidence there is weaker, and that in most cases the medication for accompanying symptoms in autism is done on an individual try and error base. So ASD is a very heterogenic condition, and it doesn't react in a uniform manner, of course. So if you think about medication, it has to be done on a very individual basis, and this has to be as individual as behavioral interventions. There is not one drug, and there is not the medical approach. But these few ideas, I'd like to try to convince you that psychiatrists might be useful partners, even in those countries where autism care is done under the auspices of behavior analysis, because behavior analysis is the undisputed lead discipline in autism. But BCBAs are such a rare species. And in my country, and not only my country, most persons with autism haven't got the choice of behavior analytical programs. They just don't exist. There are families traveling over the world and going into countries where their children can get good services. And if a family comes to my place, I first ask, well, is it possible to move to California or to Norway? If so, do so. Leave Germany at the first possibility, because care for autism in my country isn't good. But not everybody has the possibility to move to California, where the weather is better, even better than in Northern Ireland, as been told, and or to Norway to look a little bit in the close vicinity. But what they can get in some places, including Germany, is that behavior programs are done, planned and performed by clinical psychologists and psychiatrists. We do our best. What we do may certainly not be up to the standards of BCBA-led autism care programs. Well, we know how to do it if we talk with Carola, but we do learn. And the long-time data, for example, of our Münster EIBI program are up to those in the United States. even if our numbers, of course, are much smaller. And when it comes to ethics, the bioethical standards of every Western medical profession organization are totally compatible with those of the BACP. So it might be a good idea to seek for coexistence and cooperation for the time being. In the long run, I'm very optimistic that behavior analysis will be convincing enough to establish itself as an autonomous academic discipline in Europe as well. But that will need much work. And we are talking about that all the time. How can we establish this? And a country of 80 million, like Germany, can't live with 4 or 5 imported BCBAs. Well, 2 or 3 homegrown meanwhile, and there is Carola, who is one of the 2 who's speaking German as a native speaker. Well, we could need you at every university in Germany, and you could full-time teaching there, and that would make a difference in the autism care in Germany, but obviously we can't clone her. So for the time being, we'll have to live with these programs done by psychologists and psychiatrists. But that mustn't be a disadvantage, because this, as a final thought, there is no so important problem between the sciences, between analysis, behavior analysis and psychiatry, and I think we should regard each other as natural allies. Why is that the case? I think that both disciplines share a natural science concept of human behavior, may be influenced by individual conditions, by medical conditions, may be called normal. Behavior analysis is not restricted to any condition like ASD. You can do behavior analysis with any behavior people engage in. And the natural science concept means that you answer questions by what is. The example is here, why it is raining. And you know that many people will say, well, rain makes my flowers in my garden flourish, and they can grow. That's why it's raining. That's not correct. That's not a very natural science approach to the question why it's raining. It's raining because water evaporates, water collects in clouds, it condenses and precipitates. That's I think a behavior analyst would explain rain like that, like would a chemist. And a psychiatrist should do it as well if he is not a psychoanalyst. These disciplines are both strictly empiric, working with observation, measurements, and data. And while there is a not very, I think, fair and balanced view of natural science versus other sciences in Germany. You know Pippi Longstocking? This is this little girl, and she by the famous Swedish writer Astrid Lindgren. And Pippi Longstocking has her songs, and one of Pippi Longstocking's songs is "I make the world like I want it to be." And we call this Pippi Longstocking in Germany is Pippi Langstrumpf. And we always say, well, if someone is not working evidence-based, he's working after the Pippi Langstrumpf principle, which says, I don't know how the world is in reality, I just imagine it to be like it should be. That is fine for children's books, but it's not very good for evidence-based of interventions. If someone is not on the Pippi Langstrumpf principle, he should be regarded as an ally, as autism care is. And in Germany, as well as in other countries without a strong BA community, so in most countries, the authors of the autism treatment guidelines, for example, for state-funded healthcare sectors, are mainly psychiatrists. It is just the case. You won't find a behavior analyst in Germany who would counsel governments or healthcare system, because they just don't exist. And psychiatrists say, well, it has to be done behavioral, it has to be intensive, it has to be done early, and everything that the official guidelines, even in a country like Germany, say about autism care could be underwritten by everybody who is in the field of behavior analysis. So they should strongly support behavioral interventions because they see the work in other countries. The question is, does it work? Yes, it does work. And in the few local institutions delivering them. And the ideologists, the Pippi Longstocking people, well, I like the books, but not as a base for science. The ideologists, on the other hand, tend to answer questions not by what can be measured or proven scientifically, but by fits the idea. And that is true for so many so-called autism therapists still following Bruno Bettelheim. Do you know Bruno Bettelheim? This is the author who wrote in the 70s about refrigerator mums. The idea was, oh, there's a child, is born, looks at his mum, say, hello, mum, oh, you're so emotionally deranged, I decide not to speak for the rest of my life. That's nonsense, that's complete nonsense, but it's 70s, and in the 70s their mothers were also responsible for schizophrenia of their children, and so on. And this nonsense is still taught in some German universities, you won't believe that. And this nonsense, this Bettelheim thing, is still the basis of work of some so-called autism therapy centers in Germany. So that's what I would call ideology. And there are still those rejecting all behavioral interventions because they say, well, that's a human rights issues. We have got very militant internet blogs in Germany opposing ABA, even speaking about death threats, because they say, well, if a child doesn't want to engage in speech and communication, that's its autonomous decision. And if you try to change that by behavioral intervention, that's something very close to torture. That's a massive human rights violation. And our main sponsor for welfare activities in Germany, Aktion Mensch, which pays for early interventions for people with disabilities in every age and for children with different disabilities, for blind, for deaf people, they are under massive pressure of the anti-ABF movement to stop financing anything which has to do with behavior. Because they say, well, that's a very strange, distorted concept of autonomy that a 2-year-old child decides voluntarily not to speak and not to interact and not to communicate. And in this point of view, everybody who works with this child, with this family, to enhance these possibilities, to broaden his possibilities in life, to develop speech, to develop autonomy, well, he is someone who is a human rights violator. This is totally absurd, of course, from an ethical point of view. And here again, I think psychiatry and medical science, every medical science and behavior analysis are natural allies. There are 4 bases in all bioethic conventions and professional ethics, say respect for autonomy, but it must be autonomy of people who are able to exert autonomy. And no 2-year-old child has complete autonomy, be it autistic or not. I don't know any parents who give autonomy to their child to decide whether to cross the street when the red light is red or if it isn't. And this is the distorted concept, and I think that the professional ethics of behavior analysts and psychiatrists are totally identical in this point of view. The second bioethical principle is non-maleficence. The things you have to do have to be good, or at least they must not be harmful. That is totally compatible in ethics of psychiatry, ethics of clinical psychology, and ethics of every health profession, and of course of the ethical standard of the of every BA community and board. So the last, then there is of course the aspect of justice, of fairness, and even under the aspect of fairness of resources. Of course, we mustn't spend money on things that don't work, and if someone has a need, we have to address this need with methods that work. You wouldn't accept a hospital in which surgery is done without anesthesia because, well, you wouldn't survive that, or perhaps you would survive that. And surgery is done in the Middle Ages without anesthesia, but the results are not so very convincing. But in care for autistic people, there are many countries who say, well, just do it without BA. And I think that is cannot be done under the point of view of justice, which is the another important bioethical principle which is well totally compatible. So whatever I read, and it's always about ethics, if people don't want to talk about money, they say it's unethical. Well, they say, don't make a child speak that doesn't want. Don't make it go to school and take part in school education if it obviously doesn't want. And if the child doesn't say, well, I want to go to school, then let it stay at home. Wouldn't you do that? Huh? So that's the German discussion, totally absurd. So if I read ethics statements from behavioral analytical bodies and look at medical ethics, they are totally compatible. That's not a problem. So I thank you again for the invitation and the many ideas and impulses we as psychiatrists receive from behavior analysis. In an ideal world, there is no such thing as an ideal world, but let's dream. BA-led programs should provide a consultant psychiatrist, I think. And what is more important, those psychiatrists working in the field of autism should be able, for example, to apply for a board qualification. This is not made easier by the new regulations of the board, which say medicine is not anymore on the list of eligible entry qualifications. But I hope that conferences like this can help avoiding misconceptions so that multidisciplinary cooperation can further flourish in the interest of persons with ASD. I thank you very much for your attention and wish us a good further conference.